Hi, this is Tom Moe, University of Iowa. We're showing you a case we did with Aaron Rick, who's one of our grade third-year residents who's doing this surgery. You can see we've got a patient that has very loose zonules, presumably from trauma. And while we're doing the rhexis, we first go away from the good zonules, but then we run into trouble. And so we use a single iris hook here just to give us some support in the capsule while we're doing the rhexis. And what this does, it just gives us some support to pull against while we're doing the rhexis coming around this corner. We're going to use a little cohesive viscoelastic just to tee ourselves up here. And the rest of the capsular rhexis goes pretty well with this little bit of extra support. When we come around the bend, we get it out of the way so we don't run into it. And just move that hook over as shown and complete the capsular rhexis. So now we're going to use these MST capsule retractors. We've already done some cohesive viscodissection, so we have space between the capsule and the lens, but we're placing this MST retractor, and we've got 4 of them now, and it's amazingly solid once you get 4 of these in place. The nuclear fractus was relatively unremarkable, and Dr. Rick did just a wonderful job of getting rid of the nucleus, and now we've got some cortical material. You can see the zonules are still pretty weak, especially in that one area there. And so we avoid that temporarily. We're going to place a capsular tension ring, and we'll get to that later. There's a very dense posterior capsular plaque here, which is common in these white cataracts in young folks. And so we get the visual axis clear, but still you can see the bag is very loose over in this area. So we're going to place a capsular tension ring. We're going to use this technique that we learned from Dan Bettis here at the University of Iowa, and that's to use a Sinskey hook to guide the leading haptic around so that there's very little trauma, and most importantly here, so that the capsular tension ring doesn't inadvertently go through one of those retractors. You see what a wonderful job he did. This is a little bit tricky using both hands like this. So now we've placed the capsular tension ring. We can remove the MST retractors, and the lens capsule is pretty stable. You can see we tweak on it a little bit, and it's pretty stable. So we think we can use traditional optic capture. So here we're going to place this 3-piece MA50 lens into the sulcus initially, with both haptics placed in the sulcus. And now we're going to prolapse the optic posteriorly so that it's captured by the anterior capsule. And this is an extremely stable configuration. Both for long-term prevention of phimosis and short-term to have the haptics and the capsular tension ring. Patient's done well so far. This is Tom of the University of Iowa. Thank you.